My name is Xiaoxi Yao. I'm a health services researcher at Mayo Clinic. I'm affiliated with the Department of Cardiovascular Medicine. I'm associate professor of medicine in the Department of Cardiovascular Medicine. I'm also associate professor of health services research in the Department of Health Sciences Research. The study was funded by the Robert D. and Patricia E. Kern Center for the Science of Healthcare Delivery. And Dr. Noseworthy and I are both affiliated with the Kern Center for the Science of Healthcare Delivery.
Hi, I'm Peter Noseworthy. I'm a cardiac electrophysiologist at Mayo Clinic in Rochester, Minnesota. I'm also the medical director for our ECG and physiologic monitoring lab, which is the internal core facility that processes all ECG and electrophysiology data for Mayo Clinic. We've also been using that data to drive a project and a program within it to use artificial intelligence to leverage what we're doing clinically and on the research and innovation fronts. Most people are aware of what heart failure is, a weakened heart muscle, which produces symptoms and increases the risk of mortality and other serious outcomes. But there are people in the general population who have a low ejection fraction and may not even know it. And it's hard to find these patients. Various approaches to screening have been proposed over the years. But what we've decided to do is to use the ECG as a potential way to identify patients who we think may have low ejection fraction. Most people watching this will not think of the ECG as a screening test for low ejection fraction, but leveraging the technology of artificial intelligence and in particularly a convolutional neural network, we've leveraged a large data set of people with paired echo and ECG data, and the network has learned to identify features that are present on the ECG that correspond with low ejection fraction detected on echocardiography. So in a sense, we're using the ECG as a surrogate for detection of low ejection fraction. We developed that technology and published that work, and then have done some external validation, and we've looked across various racial and ethnic groups, and we have a lot of confidence that actually that ECG algorithm can help us identify some of these patients that may previously go unrecognized. So the next goal of this was to figure out how we can test this in everyday practice. So we wanted to get these results in the hands of primary care physicians, people who are taking care of patients who may not have known heart failure, but in whom it may be lurking, and see if we could identify patients in our general primary care practices. Mayo Clinic has a large Midwestern health network, essentially, across Minnesota and Wisconsin, and we deliver care using these care teams. And what we've done is randomize some care teams to receive the result of the AI, whereas others did not receive the result. And along with the result of the AI, we gave recommendations to order echocardiograms if it was felt to be reasonable by the treating primary care doctors. So what we're really trying to test is, even though we have confidence that the algorithms can work in the abstract, does it actually work when we implement these in routine practice? And can we identify patients with low ejection fraction? And can we do so without running up hospital costs or utilization of echocardiography and other modalities?
So the intervention in the trial is the access to an AI ECG report. So clinicians randomized to intervention will have the access, and clinician in the control group will just have their normal access to their EHR, so they won't see the AI results. So the trial was conducted in 45 Mayo Clinic primary care practices, including an academic medical center here in Rochester, as well as community and rural clinics. Just like Peter just mentioned, we have a number of clinics across Minnesota and Wisconsin. And the study participants are primary care clinicians, including physicians, physician assistants, nurse practitioners, and 358 clinicians from 120 care teams agreed to participate. And we randomize half of the teams to intervention and half of the teams to control. We randomize at the care team level just because physicians or clinicians on the same team may care for the same patients. So when there is a positive AI screening result, clinicians will also receive an alert to just say like your patient have a positive screening result, please consider an echocardiogram. So a positive screening result means a high likelihood of having low ejection fraction. So we recommend clinicians to order an echo to confirm, but the decision is up to the clinicians and patients. So if clinicians eventually decided, oh, this patient probably doesn't need an echo, we ask clinician to fill out a one question survey just to select a reason why you chose not to order an echo. So this will also inform our future implementation. So during a period of about 8 months, there were 22,641 patients received an ECG at Mayo Clinic. That ECG can be for many different indications. And these patients were cared by these primary care clinicians. And positive AI results were found in about 6% of the patients. And when AI was positive, clinicians in the intervention group obtained more echo. But in the overall cohort, the echocardiogram utilization was quite similar. And the intervention increased the diagnosis of low ejection fraction in the overall cohort by a relative increase of 32%. The odds ratio was 1.32. And among patients with a positive AI result, the odds ratio was 1.43, about 43% relative increase.
Well, the study proved that we can pick up new cases of low ejection fraction by running the AI on ECGs that were performed in routine clinical practice for a variety of indications. And we did that without obtaining a lot more echocardiograms overall. In fact, it did not overall increase the overall utilization of echocardiography. So it demonstrates that we can do this at relatively low cost, and we can embed it in existing workflow. The other thing that I want to emphasize is that this study was not done in cardiology or with AI experts. This was executed in our health system in a mix of rural and other primary care practices. And this is basically real world implementation. So we could have probably picked up the same number of low ejection fraction cases by screening everybody with echocardiography, but the cost would have been enormous. And this demonstrates that using existing technology and using the care pathways that are already in place to obtain ECGs, we can actually bring new value to those studies and identify people that previously would have slipped through the cracks of our health system. So as we have growing confidence in the algorithm, the next question is how do we implement it and get it into the hands of people who could use it? And we can see that it's not just valuable for cardiologists, but it's valuable in primary care and across a variety of aspects of the healthcare system. So Mayo Clinic has now made this and other algorithms readily available through our Epic electronic health record. There's a tab, clinicians watching this video who use Epic will know, you can go into a document viewer or any of these areas to show ECG results. From within that, there's a single sign-in that brings you to a ECG AI dashboard that reports all of these AI algorithms at the point of care. And then clinicians are left to see those results and think about how they can integrate that into their care. So I think there's going to be a lot of work yet to be done about giving clinicians guidance about how to use these algorithms most effectively and where they are valuable and where it may break down. But we're now starting to actually get this into the hands of the clinicians, and that's what we're most excited about.
So our trial has a hybrid effectiveness and implementation design, which means we not only evaluate the effectiveness of the AI, but also the implementation strategies. So during the trial, we conducted surveys and interviews with clinicians. For example, we interviewed 5 care teams with the highest compliance with AI recommendations and 5 care teams with the lowest compliance with AI recommendations. So this approach is called positive deviance approach, which is commonly used in health services research to understand why and how some people with similar resources and circumstances outperform others. And the successful strategies can be then applied to help improve the performance of other teams. So based on these results, we will further improve our implementation strategies.
I think clinicians that read and hear about this trial will see one message, and that's that we're likely to see more and more of these kinds of AI algorithms implemented in practice, and the role of AI in medicine is likely to grow with time. We can expect that there will be successes and failures along the way, and it's going to take some work to figure out how to use these sorts of algorithms intelligently and in a way that benefits the practice of medicine, makes our work easier, and ultimately translates to better outcomes for patients.
So this pragmatic trial demonstrates how we can evaluate and implement AI at a fast pace and low cost. So traditional clinical trials are very expensive and time consuming and are often conducted in highly controlled environments in selected patient populations. By contrast, our trial is a pragmatic trial embedded in everyday practice to efficiently generate relevant evidence. And the entire trial was completed in less than 2 years. And given the increasing number of AI tools being developed every day, so I hope our trial can show people like how to conduct rigorous and timely evaluation and implementation. The trial was feasible partly because the data infrastructure here at Mayo Clinic that enables access to our EHR data longitudinally and in real time. And the variety tools are already used in our everyday practice to serve as clinical decision support and quality measurement tools. So we adapted these tools to determine patients' medical history and clinical outcomes. And then the evidence generated from this trial was reported to, or it has been continuously reported to practice leadership to facilitate future implementation. So this current work represents a great example of a learning health system that forms like a feedback cycle of continuous learning and improvement.
Thanks a lot for the opportunity to speak about this trial today, and thank you for watching.